Got it. I remember that time. Okay, let's see. Share screen.
You've been doing a little better, Mr. Allen, these last few classes.
Yeah, it's more than halfway through the semester. You think I'd know by now. Okay, posture. Here we go. Okay, so what is posture? Well, okay, so let's talk about the different curves of posture. So you know what your adult spine looks like now, but let's talk about the posture that we are born with and that forms in utero. So they call it the classic C posture because if you look at this, if you look at the way all these babies are laying and asleep, they're all in what we would call the fetal position. Well, look at this drawing on the lower right-hand corner of your screen, and you'll see that the cross section, the whole spine is convex on the posterior surface and concave toward the anterior surface. So it forms almost like a C. So we call that the C curve. Okay. And that's how all newborns are born, or those unless there's something that goes wrong. And that's how we form. But then pretty soon we start to develop what we call the S curve of the spine. So whenever we do this on our own, we actually force our spine to, as we're developing, to change shape. So look at the picture of this baby down here on the bottom, or he is still a baby. So a few months ago, he still had the classic C-shaped curve of his spine. But look at what he's doing now. He's laying in prone. So he's stretching out that C shape into a straight line, and he's starting to extend his head. He's starting to bring his legs up in the air, extend his legs against gravity. So that's the way that we get our classic S-shaped curve of our spine, is we do that on our own through development and through movement and as we're developing. So you can see that we have a, well, it depends on where you look at it, if what's convex and concave, but, well, no, it doesn't. So the neck is convex on the back, posteriorly, and then the thoracic spine is more the cervical spine is more concave posteriorly. Let me say that it's more an extension. The thoracic spine looks like it's in a little flexion, so it's convex posteriorly. Then the lumbar spine kind of curves the opposite way again, and then it's concave posteriorly, and then the sacrum, which those segments are fused together, that goes back into another convex shape. So just remember that how we form the spine into the S shape is when we're babies, when we're starting to go into prone, when we start to extend our head and our legs, and then especially when we start to stand and walk. Okay, so at the same time we're developing our more mature alignment of the spine, we're also getting certain muscles strengthened at the same time. So if you remember, let me go back to the slide, this picture of the baby, everything I said that he was doing to change the shape of his spine is because he's in prone and he's working his extensors. Well, let's go back to this next slide again. Most of those muscles are the extensor muscles, and we would also call those the anti-gravity muscles. Okay, now if you were to think of it, all those muscles. So think of when you're and imagine this, and if you can't imagine it, then just stand up and try to picture it and feel it in your body as I'm saying it. most of the muscles, and I'm not going to say all of the muscles, but most of the muscles that keep us upright and erect when we're standing are our anti-gravity muscles, okay? Those muscles are mostly along the posterior surface of the body. So think about the erector spinae muscles going all down the spinal column. And you've got and that goes from your cervical spine all the way down to your lumbar spine. And the extensors and the extensor spinae are made of a couple of different muscles. And then you've got your glute muscles that are in our hips. They're not on our spine, but think about it. If we were standing and then our gluteal muscles just went fully relaxed, what do you think would happen? Or if any of those anti-gravity muscles just went suddenly limp when we were standing, what do you think would happen?
We might fall.
You would just fall right on over. That's correct. But then think about this. We're talking about all those muscles being on the posterior surface of the body and calling those the anti-gravity muscles. Some of you might be wondering, well, what about the anterior muscles? Can those be anti-gravity? Well, let's think about that. So if the abdominal muscles were turned on more than the extensors, then we would flex our trunk forward and fall. If we turned on our hip flexors more than we were standing, we would flex our hips and we would fold forward. So that means that most, and I'm not going to say in every case, don't chisel this in stone, but most of our anti-gravity muscles are going to be on the posterior surface of the body. Okay. Excuse me. Okay. Well, let's talk about balance now, since we just got through talking about those anti-gravity muscles. Well, whenever we're standing, and let's say we're standing and we're just standing still and statically, we still have a certain amount of postural sway that happens whenever we are standing still. And that happens from breathing, that happens just from us turning our head from side to side. And see, that already turns into dynamic. So it's really hard to talk about static stance because we're really almost always doing something dynamically when we're standing. But my point of this slide is to say that when we're standing, we're always shifting our weight a little bit side to side. Like if you tried to stand up and stand in the exact same spot for more than 1 minute, you would get antsy and you would want to shift your weight side to side from one foot to the next. You would want to maybe shift forward and backward. So all those things we do, we can do that, those little postural sways, but look at where the axis of the motion is. We're not when we do those postural sways, we're not really bending, we're not really flexing or extending our trunk more. We're not really flexing or extending our hips mostly. We're mostly just doing a little bit of a sway. But look at this picture. Look at where the axis of all that sway is. Where is this axis showing the sway is? Anybody?
Anterior.
Okay. What I'm going for is what part of the body looks like it's the axis of all the sway?
The feet?
Bottom.
The ankle. Yes, the feet, the ankle. So this is what we actually call, and this is actually a real term, it's called the ankle strategy. What that means is when we're standing and we have minor postural sways, or if somebody comes by us and maybe while they're walking past us, say you're in HEB and you're standing at what are those things called? I just lost the word. The aisle. You're standing in front of the shelf, and the aisle is in front of the shelf, and you're looking at certain items. If somebody comes by you, and it's usually crowded in those aisles, and they accidentally bump you just a little bit, And I'm talking like barely enough to where you even notice it. It's not enough to jar you, but it's just enough to kind of make you sway just a little bit. When that happens, the tiniest amount of postural adjustments that we have to make in order to keep our balance, we do that with the ankle, and we call that the ankle strategy. So the ankle strategy is going to be there to keep our balance and our posture. Does that make sense? Okay, the most minor balance adjustments are done with the ankle. let me go. Okay, before I move on, let me just say a few other things. Now, the next strategy up would be called the hip strategy. And that's not in this lecture, but I feel like if we talk about the ankle strategy, we got to talk about the other strategies. So the hip strategy would be if you are, let's use that same example. You're in, oh no, let's change examples. Let's say you are playing catch with somebody. Just say you're throwing a ball, just a ball back and forth. And the person that throws the ball suddenly throws the ball really hard, and you catch it, and you don't have to take a step to catch your balance, but it really makes you sway a little bit. Well, when the sway is too small for the ankle to take control of, then we go to our hips and we call it the hip strategy. And in that case, you can probably imagine this, you would sway at your hips. You might sway from side to side a little bit, or bend your hips, or extend your hips, or side bend, but eventually you keep your balance again. And that's all without taking a step. That's called the hip strategy. And then the last balance strategy that we have is called the stepping strategy. Now let's keep that same example that we just used. You're throwing a ball back and forth, and say your partner throws it super hard. When you catch it, all that force and the momentum of the ball kind of pushes you back, and you have to take a step in order to keep your balance. When you do that, that's called the stepping strategy. So you can think about our balance strategies in terms of degrees of difficulty, or how much we need to keep our balance. So the ankle strategy would just be done at the ankles, and that's the smallest amount of postural adjustment that we need to keep our balance. Then the hip strategy, it's a little bit more adjustment to keep our balance. And then the stepping strategy is what we would do in the last instance in order to keep ourselves from falling. Any questions on those strategies? I think I need to speed up a little bit. Okay, why? I'm not going to read this word for word, but why is good posture important? Well, the better your posture is, the less stress you're putting on bones, the ligaments, the muscles are having to work least. So when we're standing with good posture, it's actually very energy efficient for our body. Our body doesn't have to do a lot of work whenever we're standing with good posture. Whenever you're sitting or standing with bad posture, it actually makes your body do more work. So you don't have to do this right now, but in order to think about that, try this example after class today. Stand up and then stand with your knees locked into extension. And think about how much work your legs are having to do to keep you upright. And then after you do that for a few seconds, flex your knees and stand with your knees slightly bent. And then notice how much work your legs are having to do. I won't tell you the answer, but you'll definitely and instantly be able to feel the difference whenever you do those two. So try those two today. It'll show you how much the energy requirements are whenever you have bad posture. Okay, so let's talk about how to evaluate somebody's posture. So obviously we're going to do we're going to look at them as standing. Well, we want to look at them from a lateral view from the side, from the front, and from the back, because there's going to be things that you see from each of those. Now, also don't forget to look at sitting posture and supine posture. Now, you might think you may have never even thought of us having posture and supine, but posture is just the way that whatever position your body is in at a given time. So even in supine, when you're in supine, that's a posture. That's a supine posture. And when somebody's in supine, the reason you might be looking at them to evaluate their posture, you might see certain deformities there in supine that you might not see in sitting and standing. In sitting, you might see certain things that you would never see in standing. So it's important to see all of those. Well, let's talk about some common postural deviations. Okay, so the first picture here that I show was just a normal posture. It's just a normal S curve. Then the next posture is going to be what we call increased thoracic kyphosis. So the curve that we have in our thoracic spine is already a slightly kyphotic curve. But if you are somebody that hunches over a lot, or if you are if you're an elderly person that has bad posture, you might have what you call somebody that's hunching over on their upper back. We call that increased thoracic kyphosis. Okay. Now, almost the opposite of that is if somebody has increased lordosis of their lower spine. That would be where the spine is curving in. I would say the most common example of somebody having increased lordosis are pregnant women. And especially toward the end of their pregnancy, when they're toward the end in their last trimester, when the baby is bigger, you can look at them from the side, and because they're carrying so much more weight on the anterior surface of their body, their lumbar spine curves inward, and they have an increased lordosis. Now, I'm not saying that every pregnant woman is going to have that, but it's very common with pregnant women. Now, you don't have to just be pregnant to have an increased lordosis. Some people just have an increased lordosis anyway. The last example would be scoliosis. And all of you have heard of this before. This is a curve of the spine in the frontal plane. So all these other curves we've been talking about have been in the sagittal plane. The scoliosis occurs mostly in the frontal plane. And you can see that that's a curve to one side or another. And I bet that almost all of you probably remember getting checked for scoliosis in elementary school. I remember that. And as adults, people that have scoliosis, there's certain degrees of it. There's definitely certain degrees of it, just like there's degrees of other things. If you have a minor degree of scoliosis, sometimes they may not do anything and you may grow out of it. Or it may be something that as you develop, it's just not something that really bothers you. Those that have it, that still continue to have it as an adult, may do well with just certain stretches or strengthening exercises to prevent it from going even further in the curve, because it can always worsen. Those that have a certain amount of curve to where it can become problematic, then they go ahead and they straighten that out, usually as children or as soon as the person can. And what they do, they go ahead and they fuse some of the vertebrae together, and they put metal rods along the spine to keep the spine in a straight line. So that's just a little bit about the different kind of deviations of the spine. That's an extreme example of kyphosis. Okay, here's some more examples I was talking about. So you can see this lady in the black tank top. She's obviously pregnant, and look how much her lower back is curving forward. Look how much that concavity is. That's not, now for a pregnant woman, that would be natural, but for a normal person that's not pregnant, that would be too much lordosis. That would eventually cause a lot of back problems. And that's one reason why pregnant women do complain a lot about back problems. Look down in this picture down here. Now, I don't know how clearly you can see this picture on your on the shared Zoom and how small it is, and it's not a very good animation. But if you look at where I'm circling my mouse, you can see this person looks like he's doing a plank. Well, his lumbar spine is curving in, and these lines kind of show, it kind of is supposed to show like he's having pain. So if you have a weak core, your lumbar spine is going to be at risk for developing increased lordosis. And that will cause increased pain. You may have disc herniations, nerve impingement, things like that. Okay, so any questions before we move on? Any questions on the different curves of the spine before I move on? I'm going to stop sharing just for a second so I can check myself to see where I'm at, to make sure I'm not too far behind or ahead. No, I'm good. Okay. Just had to see if I needed to speed up. Okay, so now let's talk about the pelvis, how the pelvis plays a role in posture. So I don't know if y'all heard of this in anatomy yet, but there's three main different postures that our pelvis can be in. So our pelvis can either be in a neutral alignment, it can be in what we call an anterior pelvic tilt, or a posterior pelvic tilt, okay? Now, Ms. King made up this really good example one time, and I don't know if she's ever shared it with y'all, but I like this example, and so I use it now. So y'all have all seen in anatomy what the pelvis looks like when it's all put together. Well, think about your pelvis as being a bowl, like a cereal bowl, okay? I know it sounds funny, but just bear with me for a second. If you're standing with good posture and with a neutral posterior or a neutral pelvic tilt, your bowl should hold all your cereal and all your milk. Well, if you have an anterior pelvic tilt, that means that your ASIS is down lower than your PSIS. That means all your cereal is going to spill out the front of your bowl. So that means the anterior surface of your, I got kicked out, sorry. The anterior surface of your pelvis would be much lower than the posterior surface of your pelvis. And then to the opposite of that, if you had a posterior pelvic tilt, then the ASIS is higher than the PSIS. That means your cereal is going to spill out the back of your bowl. And you can see what the different postures look like here in this picture. Now, I will tell you, those anterior pelvic tilt and posterior pelvic tilt pictures, what he's doing, he's really exaggerating what he's doing for the sake of the picture. It's usually not quite that obvious, but it usually is. The way that I do it, the way that I can tell is if it's not visually obvious, I will get from the side and I will palpate the ASIS and the PSIS, and whichever is higher or lower, that lets me know which way the pelvis is rotated. So remember, if the ASIS is lower than the PSIS, you're in anterior pelvic tilt. If your ASIS is higher than your PSIS, you're in a posterior tilt. And you can also see by this picture what that does to your spine too. So when you're in more of an anterior pelvic tilt, you get more and more lumbar lordosis, as opposed to a posterior pelvic tilt, you get almost no lumbar lordosis. Now, think about this. I'll tell you this right now. Sitting in a chair the way you all are right now, most all of us, unless you're sitting up with good, proper posture of your whole entire body, you were probably sitting in a posterior pelvic tilt. That's how most of us sit and rest. Somebody's turning a lot of pages and it's very, very loud. Can you mute yourself? Thank you. I don't know who it is. So you can see what this does to the spine whenever you posteriorly rotate your pelvis. Okay. Now, let's talk about the postural plumb line. Now, by lab, let's see, by lab on when I get to lab on Friday morning, what I'm going to do, I might get either Dr. K, if he's brave enough, because he's tall, or one of you brave souls to climb up on a ladder and hang something from the ceiling for me. What we're going to do, we're going to learn how to analyze posture from a side using a string hanging from the ceiling with a weight on it. So let's look at this middle picture first.
Mr. Allen,
Yes.
how would you document that? Would you just put poor posture?
You would say poor posture, but you would say why, like where they're having, like you would say like patient is standing with increased thoracic kyphosis, or patient stands with posterior pelvic tilt or something like that.
Okay.
So let's go back to this guy in the middle, and this dotted line that is going right down the side of him. This is, picture this as the string that's going to be hanging from the ceiling in lab. Okay. So whenever you want to analyze somebody's posture, it's before, if you're a newbie, it's good to use the string method, the plumb line method. Well, look where this string is going in relation to his body landmark. So we can say when you're standing in good posture, the line goes through your ear. And there's a chart on all of this in a minute, so don't worry about memorizing it as I say it. It goes just, where's my mouse? Oh no. It goes just anterior to the acromion. It goes through the greater trochanter. Okay, it's going to go through the knee, just posterior to the patella. And then it's going to be slightly anterior to the lateral malleolus, if not through the lateral malleolus. Okay, now let's take this example of poor posture, this on the left hand side of your screen. This is somebody that might be, well, we might see somebody like this in clinic that doesn't extend their knees. So you can see that the plumb line, you could, if you were documenting this, you would say patient stands with plumb line behind. You could say the ear is in front of the plumb line. The shoulders are behind the plumb line. The greater trochanter is behind the plumb line. It's still going through the knee, but it's way too posterior through the knee. And it's too anterior to the medial, or to the, I'm sorry, the lateral malleolus. And that's how, and the same thing you would do over here. So this guy would have the plumb line going, it doesn't matter. And let me tell you this, it doesn't matter if you say the plumb line is going behind the ear or the ear is in front of the plumb line. It means the same thing. Just stay consistent with the way you say it. And I don't care, and on test, I don't care if you tell me that, say, the greater trochanter is behind, I'm sorry, with this one, I don't care if you tell me the greater trochanter is in front of the plumb line or the plumb line for posture is behind your greater trochanter, because both of those sentences mean the same thing, and I know what you mean. Just be consistent with how you say it, and you'll get more practice with this, so don't worry. Okay, and then this is just a little chart to if you do better by charts, this shows you what this is just kind of like where the plumb line should go whenever you're looking at somebody from the side, from a lateral view. So just keep this handy as you're looking and practicing on people, and practice with your family members at home this weekend too. Okay. This I do like this slide a little bit, but there are some problems I have with it. This picture just shows you what muscles tend to be working more, and what's tighter and what's weaker during certain postures. You can see here that on somebody that stands with too much lordosis, they've got, and the red stand down here stands for tight. So you would expect a person with too much lordosis to have really tight lower back muscles. But because you can think about this, if you are tight on one side of your body, you're automatically going to be weak and overstretched on the opposite side of your body. So in this picture, if the lumbar paraspinals are weak and overworked, then they're tight and overworked, then the abs on the anterior surface, the opposite surface, are going to be overstretched and weak. And I will tell you that is true in those cases. Let's look at this person that has kyphosis and lordosis. You can see that all these muscles are being overworked and they're tight, and all of this in the front is weak. And you can even see, even in what they call the military posture, which is the most upright posture, and it's an exaggerated upright posture, you can still see how it shows weakness in the abdominals. So even with a lot of standing, unless you are engaging your abdominals, we really don't ever do that at all, unless we're being mindful of it, or unless we've trained ourselves to do it. Okay. What do you look at when you're looking at an anterior or posterior view of the posture? Well, you want to look at everything. So let's see. You want to look at their toes and their knees. You want to look at, let's say their toes. What would you look at their toes? Well, you want to look at, are their toes, are their feet pointed straight ahead, or do they have one foot turned out into external rotation, or are both feet turned out? You want to look at their knees. Are their knees in extension, flexion, or are they hyperextended? You want to look at you might look from the sides at the ASS and the ISS, the level. Where it says gluteal folds, I mean, you might wonder, why do I have to look at that? Well, that would show you if they have a leg length discrepancy, if one leg is slightly longer than the other. You want to look at their scapula from the back, because you may see one scapula higher or lower, or one that's more rotated than the other. The shoulders, you may see one shoulder higher or lower than the other, or maybe leaning to one side maybe more than the other. So all those things you'll look at. But the reason you don't want to get confused and look at everything at one time is because you will get confused. So you want to look at one what am I trying to say? One view at a time. So you would go lateral, and then anterior, and then posterior, or any order, as long as you do them separately. And you may see some things on the same, you may document some of the same things on the same ones, but many of them will have different ones. But I will say the lateral one will probably be the one that you fix the easiest. Not always, but easiest. Okay, so this is how we should look from an anterior view. Everything should be even. And you can see the plumb line drawn again here from the side. Okay, let's talk a little bit about sitting posture to end this. So sitting ergonomics are a big deal lately in out there in the world, because a lot of jobs are, more and more jobs are becoming desk jobs, and more jobs are becoming more sedentary jobs, or less manual work than what we were typically used to doing with just how we were before. So this picture of this, it looks like an X-ray. That shows you kind of how I'm sitting right now, looking over my computer, and that's probably how half of you are sitting right now too. Now, that's not just a computer posture. That's how we look at books. That's how we look at read. If you think of our phones that we have, of cell phones, we usually keep them in our lap and we're sitting down and typing with our thumbs, but we're looking down with our head and we're punching over. So we're just technology and just life itself has just not been good for our posture, for the human race, the last few years. But if you look at this animated picture here, this is an ergonomic setup that is actually ideal for somebody doing a desk job. And so, some of you may even go in and specialize in ergonomics. There are companies that hire therapists to just go to work sites and do ergonomic assessments for their employees. So that's something that you may get into one day. I'm sorry, got to silence my phone. So let's look at this from the ground up. So obviously it's more comfortable if and you can probably attest to this, if your feet are flat on the floor. Okay. Now, when you're sitting in your chair, you want your knees bent to a 90 degree to 110 degree angle. So usually, now, if for comfort, sometimes we may straighten our legs out in front of us, but for a proper posture to keep our pelvis in line, right, we want it to keep our knees slightly bent around 90 degrees. Okay. You want your femurs to be pretty supported by the chair, and you kind of want them parallel to the floor. And you want to be able to sit all the way back in your chair to where the back of your back and the top of your sacrum is touching the backrest. Okay. Your arms should be supported at the elbow and not to where and if you look at me right now, you don't want to be sitting with armrests with your arms where they're high, where your shoulders are hunched up way over you, or with low armrests where you can't touch them. You want your armrest to be just perfect length for your elbow. And so that if you have your hands on the table, your forearms on the table, typing or on the mouse, that your forearms are completely parallel to the floor. And you want the top of your monitor to be at the top of your gaze. So you can think about it, you can think of, I want my webcam to be at eye level with me. So if that means you're on a laptop, to have proper screen length height, you may need to put it up, stack something up on something. But that doesn't help with the keyboard on a laptop. That makes that worse, so we can do that. But most desktop monitors are very adjustable. And there are a couple of products out on the market right now for laptops that make it more ergonomic, that kind of make it to where the back of the laptop is higher. Like if this is the laptop opening, this top, look at me real quick, this is the screen, and you've got something like a wedge under the bottom of the laptop building it up so that the camera will be higher and more at your eye level, and it will keep the keyboard at a slant so that you will be in more of an extension position in your wrist rather than flexion. So if you know anything about people that do a lot of computer work and that spend a lot of time with their wrist in flexion, those people tend to be the people that get what disease? Anybody take a guess?
Carpal tunnel.
Carpal tunnel syndrome. Very good. So you don't want carpal tunnel. Okay, so let's practice real quick. So let's look at this guy. Hopefully this guy is exaggerating this posture. I would hate that if he really stands like this, but I'm sorry that some of the answers are there, but y'all talk to me in terms of the plumb line. So somebody tell me where his ear needs to be in relation to the plumb line, or where it is right now.
too far anterior.
Okay, so you could say, very good. You could say the ear is too far anterior to the plumb line. Okay, now let's look at the acromion.
Also too far anterior.
Also too far anterior. Now, let me ask you an extra question. This is just a bonus question. Looking at this picture, how, besides saying his shoulders are anterior to the line, how else might you describe his shoulders?
Is it like medially or anteriorly, like rotated in?
Well,
Rotated a little bit.
you can't, yes, because if you look at his whole arm, the way it's resting, he is in a little bit of internal rotation at the shoulder. Yeah, so yeah, that very good, Valerie. That is true. I wasn't even thinking of that. What I was going for was that he has more of a rounded shoulder. And a rounded shoulder happens when you have, it kind of comes with thoracic kyphosis. So when you have increased thoracic kyphosis, your scapula will drift forward over your rib cage and give you what we call a forward or a rounded shoulder posture. Okay, now let's go back to the plumb line. Talk to me about the plumb line and the greater trochanter. Where is it supposed to be?
It's supposed to be at the plumb line, right?
Yes. So it's too far behind it right now. Okay, so he is in, he's just kind of hanging on the front of his hip ligaments right there. And then what would you say about the foot? Kind of hard to tell on this picture, but take your best guess. Looks like it might be going right through the malleolus. If you even argue that it might be going a little posterior to the malleolus, I would take that too. It's just kind of hard. We can't really tell because of his pants here, but I would argue that it's either through or just a little posterior. So that's how I want you to practice this. So you can practice this with the plumb line or without the plumb line. I think a good way to get used to it is to use the plumb line, and we'll try to hang that up on Friday if somebody isn't too scared to go up a ladder for me. Or you can just we can just do it from the side and from the front, and we can go over that together too. Okay, so that is all of the lesson for today on posture. Any questions before I let y'all go?
You had mentioned looking at their posture laying in a bed. So I know a lot of people lay differently. What would you be looking for?
Well, what you would do, first of all, what I would do if I came in and I was going to do and I needed to look at posture. First, I would look at the way they're laying just comfortably when I walk in the room, just to see, like, are they laying straight? Are they laying pretty much straight? Are they all curled up in a ball? And also why they're laying in that posture. Is it because that's comfortable for them? Does it relieve pain to be in that position? And then I would look at them from sitting, and then look at their shoulders, and then I would look at them in standing. But supine is important because sometimes you might be looking at somebody's supine and sitting posture to prescribe a custom wheelchair for them. So you'll never do a standing posture. Well, to give them a custom wheelchair, you've got to know if their pelvis is equal, if their shoulders are equal. You've got to know if there's any deformities going on that you've got to accommodate for in the custom wheelchair. So that's where supine and sitting postural assessments come in the most, is during wheelchair evaluations. Good question.
Thank you.
You're welcome. Any other questions? Okay, guys. So remember, it's not mandatory, but at 12:15, you can come back here and we'll go over both of our previous tests, but we'll go over one at a time. Okay. So I'll do this. We'll do kines first. So if you don't want to look at your kines test, you can wait a few minutes, maybe till about 12:30 or 12:35, then pop on and I'll open up PTA techniques. All right, guys, you are ready to go. Unless you have any specific questions, you may go.
Thank you.
Thank you.
Thanks.
You're welcome.